Congratulations again on Precision reading out and being published today in the New England Journal. Can you tell us a little bit about how this study came about?
Sure, so it was a real journey in collaboration. We started with a systematic review in 2012. That showed us that we didn't have the standards for reporting MR targeted biopsy studies. So we convened an international collaboration with the help of the Pelican Pelvic Cancer Charity. We met in New York and defined the standards that we would report these studies to. The START consensus group then worked for a couple of years developing the protocol and gaining the funding from the EAU Research Foundation and the National Institute for Health Research, and this gave us the opportunity to carry out the study. With a big study group of 25 centres, we were able to recruit rapidly because people were really interested in the question.
Veru, can I ask you about the biopsy techniques? And by protocol it wasn't predefined and people used transrectal and transperineal, and the targeting was done with a mixture of cognitive and visual. Have you any comments about these approaches? Do you think there is a difference between whether people adopt a transrectal or transperineal approach, or indeed they have a visual targeting versus a software fusion?
So I think it's difficult to tease out from the data whether there's a difference between the different types of registration and whether one type or one access is better. But what we can say is from the literature, different types of registration, one particular type hasn't shown superiority over another. So it is reasonable to use the resources that someone has at their own centre to be able to carry this out.
I want to ask you about the pragmatic study design that we've heard much about with the Precision study. Do you truly think that this study design enables us to generalize these findings out into community practice and practices in other countries not included in the Precision study?
I do. So I think it was really important in the study that we included a range of techniques: software registration, visual registration, transperineal, transrectal. The only thing that was mandatory was to target the MRI lesion. Having said that, we had quality control. So centres didn't get into the study until they'd shown that they could target a lesion and that they had acceptable negative and positive predictive values. So there was some quality control on that side.
Veru, congratulations on your study. Can I ask you about the group of men who had a normal MRI who did not have a biopsy and underwent routine standard of care? Obviously some clinicians will be concerned about the possibility of clinically significant cancer in these men. Can I ask you what the role of a systematic biopsy is in select men with a normal MRI who perhaps have a red flag like adverse PSA behaviour, adverse family history and so on?
So I think that's an important point that you make. I think before centres who haven't carried out prostate MRI for a long time adopt this, there are measures that can be used to minimise the risk of missing clinically significant cancer. And things like PSA density, PSA velocity, and using some of the other clinical features may help in reducing missing men with clinically significant cancer who have a negative MRI.